Hi, I'm Allison Norton. I'm a pediatric allergy immunologist at Vanderbilt University, and today I will discuss updates in penicillin allergy in children. So, as we know, over 10% of children will report a penicillin allergy. However, when fully evaluated with allergy-directed questionnaires, skin testing, and our challenge, the majority of these will challenge fine and do not are able to tolerate subsequent antibiotic courses. So given this knowledge, we know that the majority of these reactions reported are not truly allergy. And there has been accumulating evidence to support that children who report benign non-immediate reactions, which is defined as a reaction occurring greater than 1 hour after ingestion of penicillin, as well as benign, typically rash only. It's not associated with any danger signals such as blistering skin disease or mucositis or organ involvement, that these reports of benign non-immediate reaction may suggest that the individual does not have an allergy, or if they do, a very benign and self-limited one. Therefore, at this point, it is recommended that children can often skip the more painful and time-consuming step of the skin prick or intradermal that we typically would recommend in the 3-tiered approach with skin prick, intradermal to challenge, and go straight to challenge. Now, this has been well tolerated in multiple studies and is definitely more accepted by our patients as well. In addition, there has been a lot of literature looking at with these challenges that definitely has some discrepancy as to if they should do a graded challenge or an oral challenge, if the challenge should be 1 day to 10 days. But of note, they found that a single day challenge in one study did pick up non-immediate reactions within a day of the challenge. Other important updates are related to periinfectious reactions that happen in children. So one particular periinfectious reaction is similar to what we see with serum sickness-like reactions. So in children, they often will have rash and joint complaints that may be related to a virus. And so distinguishing between the viral type syndrome and the serum sickness-like reaction caused by an antibiotic can be very difficult. So recently in February 2021, there was the largest study that's been published to date reviewing these reactions and challenging over 75 patients who reported serum sickness-like reactions. So they found that in these children, that only 3 of them did have some non-immediate rash, also benign and self-limited, and 2 also had immediate rash out of the 75, again, benign and self-limited. So this study suggests that the majority of children who avoid penicillins due to serum sickness-like reaction may actually be able to tolerate it, and that given that even if with failed challenges, there is typically benign and self-limited rash, that these individuals may potentially be challenged in the office by a skilled allergist as well. Thirdly, there has been a paradigm shift in SJS-TENs, or Stevens-Johnson syndrome, and toxic epidermal necrolysis in children in the recent years as well. So there's been a growing number of groups that recognize that there is often an infectious cause of the mucositis, mucocutaneous symptoms that these patients develop, and especially in children, and that there are actually 2 distinctive clinical syndromes. one of which is induced by infection and results more with mucosal involvement, usually over 2 sites, and less involvement of rash or the skin. In those individuals, they tend to have a better prognosis as well. And that in those cases, it is induced by the infection versus another group of cases that often are more severe and are drug-induced. So there is current recommendations to change our classification, and this will help improve our management of these patients, and it will also help prevent unnecessary avoidance of antibiotics as well in some of these children where their mucocutaneous symptoms are induced by infection. I hope that these updates have been enlightening to you and will improve your clinical practice. And thank you very much for listening.